Well, I guess with the delay, that means we are good to go, John.
Yes,
Dr. John
indeed.
Canisi and Dr. Bob Lowe, Ask the Dental Professors, and welcome to everybody.
Great to be here tonight with everyone.
So tonight, John and I are going to have a little discussion about the evolution of composite placement and how heated composites have impacted our one of our techniques on how to use composites. And I think we have a lot to cover. And what we'd like to do is have people put some questions into the chat area. This is going to be a little bit different of a program, in that John and I are just going to have a conversation, and we want you to join in. And we have no particular format. We've got some slides to show, but more than not, we want to hear what your questions are and see how we can answer them in regards to this topic.
And if we can make this interactive, this could be a new way of managing things. Bob and I have both found that when we're teaching our students, by enabling them to ask questions, it gives better opportunity for them to learn. And if there's anything that we can enhance with this overall program tonight, we're certainly looking forward to doing that. So why don't we start the show, Bob?
All right, let's do that. So we've been looking for a way to simplify the placement of composite materials since composites have been around. John and I are both 1982 graduates, John of Northwestern School of Dentistry, Northwestern Dental School, and me of Loyola. Unfortunately, both of our alma maters no longer exist. So
yeah, what's with that? It doesn't make any sense.
I don't know what's with that. But
it's just wrong.
We grew up in the era of alloy and amalgam was our number one direct restorative material. And during the time we were in school and shortly thereafter, composites really started to gain traction as a new vehicle, a new way to restore posterior teeth. Now, composites had been around for a while in the microfill area to aesthetically restore anterior teeth, but posterior teeth, different story. So
yeah,
John,
exactly.
have a little history on that?
They're always a big challenge there. And again, I see from the slide that we're doing this on blind faith. So when are we starting the music aspect of the presentation?
The music aspect of the presentation will actually be in part 2.
Oh, okay, cool. I can't wait.
Those of you who are old enough that are as old as John and I would remember Blind Faith as a super group between Eric Clapton and Ginger Baker and Steve Winwood many years ago.
Yep.
But today we're using that context of Blind Faith and in filling proximal boxes with direct composite, because with amalgam we got very comfortable, I think, because of the ability to condense amalgam into geometric box forms and seal cavity preparations and seal margins.
And over the years, we saw so many different products that were called condensable composites. And I have never been able to condense a composite in my career, and I'm sure you're feeling the same way. I feel that the material is more what we like to call squishable, more than condensable. And as such, thinking that you can push a composite in the same way that you condense an amalgam is certainly erroneous. And if anything, it's going to just create more challenges. And as we've seen in so many different things, we go to the next slide, we know that the box is one of the most challenging places. And as the illustration shows, that where the red line is, that gingival aspect of every proximal box that we create is where all of the failure occurs. The NIDCR has shown us in various studies that the average replacement span of a composite is about 5.7 years. And your composites and somebody else's composites might last a lot longer, but when they compile all of the data, and that 5.7 years came out as the overall number, it was rather shocking to the entire profession. So we got a question from Bruce right now that asks your best composite and techniques for class 2s. Great question,
and hopefully
Bruce.
we'll help
We're going to
answer
try
the
to answer
technique
that
portion.
Yeah.
Bruce, when it comes down to it, there's no magic bullet or magic material. I've never
Yeah.
thought, and I think when we're talking about the history with amalgam and going into composites, amalgam was very technique insensitive. You could
Yeah.
place it in a pool of saliva. Well,
Hmm.
it was you didn't have to worry about isolation. Although I mean,
Want
we
to
all know that
isolate. Yeah.
proper isolation is necessary, but not necessarily, a moisture type of moisture-free environment with amalgam. And when you get to
Yeah.
composites, there are so many places to introduce error that no wonder that number comes up 5.7. So Bruce, we'll talk about some of the different materials and techniques. And one of the techniques is going to be implementing the warming of composite when you're placing this material.
And one of the most important things in best practices is actually following the instructions for use of the products that you're working with, because they have been designed to work within the parameters that the instructions and the materials were designed for. So if you think that you're going to use product A in the same way you might have used it with product B or product C, there might be a differential between all of them in such a way that it could fail. And some of the failure is intrinsically ours as clinicians, because we don't often realize that we're putting errors into what's going on. So the best composite and the best technique is taking your time, A, and B, making sure that the materials that you're working with are actually working as you need them to work. If you're putting them into a sea of saliva and blood, as you and I well know, Bruce, it's never going to work. But if you isolate it well, and especially the isolation is not just for protecting the restoration and the preparation that you're doing, is protecting the patient, protecting that airway, protecting that gullet from getting anything from accidentally going down the wrong way. And so isolation is critical no matter what. So that's a key component. But
Yeah, absolutely.
making sure that that gingival floor is properly matrixed properly and wedged properly and sealed properly is key step number one. Number two is making sure that you place the composite and you're getting enough light energy down into that deep hole, because not all lights are going to cure the same way. Because and especially with our LED light, just because a light turns blue doesn't mean that it's working. You don't know what the energy output is. You don't know how much light is actually getting down into a 6, 7, 8 millimeter restoration preparation that you've got there. And if your energy dies out over distance, as we know it does, and you're using a light that's not giving you effective light and effective cure, that gingival floor is gone. It's become soup. It becomes, as I like to call it, and Bob knows that I love to call it, I call it the Tootsie Roll Pop effect. It's crunchy on the outside, especially up toward the occlusal surface, but it's soft on the inside. And that's where all the failure. If you have a sensitive tooth, it's possible you may not have cured that tooth completely, that restoration completely. So the patient's in pain because you got this goo underneath it. So we have to always look at that very closely. So light energy, making sure you're using a light that really provides the appropriate energy to the restoration is critical. If you don't do that and you don't adapt the restoration material, the composite, into that box properly, you're going to get voids. You're going to get all kinds of challenges to the integrity of the margin that you're trying to create.
And that's one of everything that John's been describing up to this point tells us how intricate and how difficult it is to properly place composite material. As we said, going back to amalgam, we used round instruments to plug and condense. You could hear the amalgam squeak, 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 the lathe cut particles moving closer together. We could deform matrix bands. We would take a ball burnisher and burnish the contact, and with a simple wedge, get a contact with amalgam. That doesn't happen with composite. As I always say, as John alluded to, I say it's like pushing around mashed potatoes in a cavity preparation. You can't condense. You can't do anything. The fact is, the matrix is key. The seal at the gingival margin is key. And then the ability to create a void-free adaptation of this quote unquote packable, condensable, not material is what we're going to be talking about tonight.
Yeah.
Let's move on.
And again, that's a real challenge.
It is. And so what we carried from amalgam dentistry, many dentists carry to composites. A Toffelmeyer matrix band. Now, a Toffelmeyer matrix band is definitely not anatomic. And if you can't deform the matrix band and deform the material when you're quote unquote packing or condensing it, you're going to end up with a restoration whose proximal walls look like the side of a Coke can, with the contact at the height of the marginal ridge, not a millimeter below like anatomically it should be. You can see the definite difference between the upper tooth and the lower tooth that was restored with a sectional matrix. Sectional matrix bands are concave on the inside and convex on the outside. Hey, that's what teeth are shaped like. They're not shaped like Toffelmeyers. So many of us have transferred from amalgam to composite, but continue to use amalgam paraphernalia to place composite. That's problem number one.
And the biggest challenge with the sectional matrix, though, Bob, is that those bands are so malleable that if you don't use them properly and you don't adapt them, they're going to give you almost as much trouble as a Toffelmeyer band. So being proficient in the placement of these bands and practiced with them to make sure that you've got it adapted properly, that you've created your contact point, that you've created your marginal ridge that's away from the other marginal ridge, all of these issues become a real challenge. So becoming very, very expert in placing these sectional matrices is something that's a learned response over the course of a long time in some people's hands, unfortunately.
And the other thing I do when I place a sectional band, I make sure that the contact is open. If you can't have trouble getting that band in, you need to open the contact. Either vertically break the contact with a very thin burr or use a diamond strip or something. But that matrix band, you shouldn't have to push and tug to get it through the contact. You should be able to just drop that thing into place. Because as John said, they are very malleable. And if you crunch it up, it's ruined. You don't have, remember, the composite's going to take the shape of that band. So you want to have that placed pristinely before you put the wedge.
That's a really important thing. David Clark in his BioClear methodology talks about the external the external part of the preparation. He calls what he likes to call the infinity edge. He bevels all of his external margins extraordinarily. And if any of you have never taken a BioClear class, you might want to investigate it. It's really an eye-opening and mind-blowing course to take. And his continuum is rather extraordinary. And I've taken the classes. Bob, you've done them as well, I believe.
Yes.
And they are just remarkable. It will change the way that you look at how you're restoring your teeth. Speaking
of David actually invented this particular ring design. This is Dual Force from Clinician's Choice, but David's company private labels this for Clinician's Choice. And you can see what I like about this ring is you see it takes up the space of the embrasure so that the band actually will hug the preparation much more precisely. I always tell my students, my goal is to do as little finishing and polishing as possible. With composite placement, the band placement is critical.
Yeah.
Don't want to have overhangs. Don't want to have areas where you have to go in with a disc or a burr. I don't know about you, John, but I always make it worse when I have to go in with a burr.
Oh yeah, I have gone in and completely murdered my restoration because I'm trying to perfect it. And as we both tell our students, make sure that you apply the composite and get it to the shape that you want it to be before you do that final cure. Shape it, sculpt it. And then when you've satisfied with it, then set it with the light. That's a critical component.
Exactly. Composites command set. You don't put your finishing in anatomy, in my opinion, with the handpiece and a burr, particularly after a cup of coffee in the morning when your hand's shaking a little bit, or your assistant accidentally hits the handpiece with a high volume suction and you whack off a cusp. and you have to
Where the
start
patient
over.
moves at that
Or the
last
patient
second. They
moves.
sneeze, they
Exactly.
cough, they move, and then you're at the mercy of what the heck has just happened. It's remarkable. I've
John
seen so
mentioned
many things.
isolation.
Yeah.
John, tell us a little bit about Isolite.
Oh, Isolite is probably God's gift to dentistry in so many different ways, because it can provide you with the overall ability and an operating feel that makes your job easy. It gets the cheek out of the way, gets the tongue out of the way. It's a high speed evacuation of the mouth, so that this way, when placed properly and helping to coach your patient through it, can make every procedure that you do so much easier. And at the college, we've been using the IsoVax for almost 4 years plus now, and we're just incorporating the new anterior IsoVax into place. I'm telling you, being able to get isolation on front teeth when you're doing a class 4 or class 3 restoration and keeping the lips and the tongue out of the way is hypercritical. Now, rubber dam, of course, is still the gold standard, and certainly that is what's used on every state board in the country currently. But not everybody has an enamored relationship with rubber dam. So having an alternative such as an Isolite type device, the Xeris company has come out with the anterior core, and these posterior devices have been a godsend in my private practice prior to coming to the university, and all of our students really have appreciated the ability to choose this instead of rubber dam. They're still required to place rubber dam and learn how to do that proficiently, but we like to give our students the opportunity to become expert clinicians on their own, and giving them the
And the
ability
patients like this because with the bite block,
Yep.
it allows them to relax their
Yeah.
muscles,
Mm-hmm.
and they're not moving their jaw as the patient, as I would say. Sometimes with some patients, I feel like I'm doing dental surgery on the open seas, because you have to literally move your handpiece with the waves as the patient moves, as the jaw closes,
Yep.
the patient goes to sleep, whatever. But this really makes a big difference.
It does. And for those of you who are concerned about aerosol, Isolite and Isolite devices such as the one pictured here, in our study that we did during COVID, we found that the Isovac actually reduced the aerosol in the environment significantly. And if you incorporate a secondary high-speed evacuating device next to the area that you're working, plus the Isovac, you can almost eliminate 100% of the aerosol contamination that goes into the clinic and into your room. So there are ways, if you're still concerned regarding that, and you may still be, this has been a really great godsend as well. It's what got our college through the COVID challenge, because we were able to reduce our aerosol contamination significantly because of its utilization.
The thing I like to show on this slide, you see the red arrow here. This was immediately after removal of the sectional matrix after light curing the composite. And you can see the marginal ridge placement, the contact to the buccal, the central groove, the lack of flash, the facial embrasure, the lingual embrasure. This is what you see. The marginal ridges are equal in height from one another. The more accurate you can place the matrix when placing your composite restoration, the easier the placement's going to be.
And that's a gorgeous restoration there. Very pretty.
John and I also use these in the clinic, Contact EZ. These are our nice little instruments to use interproximally. You can see this one with the orange handle here. There's a diamond abrasive on one side and a serrated edge. If you accidentally glue two teeth together with bonding resin, you can get the bonding resin out. You can shape proximal contacts nicely. Much easier than I think with the diamond strips, where half the strip goes down the patient's throat and you can't really keep the contour properly shaped interproximally.
And the potential for cutting the lips with a regular diamond strip is so significant. And Bob and I have had to use this, unfortunately, because periodically our students over burnish the sectional matrix a bit, and suddenly they can't get anything through it. So then we have to recontour the marginal ridges first to see if we can create an occlusal embrasure again to get the floss started. That's one of the challenges, understanding that you want that embrasure, that space in that upper
the occlusal embrasure.
Exactly. If you don't have that, you're never going to get floss through. And unfortunately, we have to go in and open things up.
And that's one of the reasons why I like the Triodent bands from the beginning, because the Triodent sectional bands actually have the shape that includes the occlusal embrasure. So if you place the band at the height of the adjacent marginal ridge, your contact will automatically be a millimeter below, and you'll have an occlusal embrasure without thinking about it.
Yeah.
And that's the key.
Yep, definitely.
John, you know David Pashley and Franklin Tay. Tell them a little bit about Denton bonds and some of that, because, giving a little bit of this background prior to the placement, again, there's so many different things we could talk about, which is why, by the way, everybody that's listening tonight, we are doing a part 2 to this. I'm sure at the end we could give you the date for that. But I want you to write that down so you remember that. But anyways, tell us about the durability of resin bonds, John, and MMPs and all that good stuff.
All that fun stuff. Well, I've never had the pleasure of meeting David Pashley, but I know so many people who have been influenced by him. I have met Franklin Tay, really great gentleman up in Augusta, Georgia, and does a great job. But David Pashley and Franklin Tay and so many other giants out there have been talking about the challenges of resin bonds for years.
And Salvatore Soro.
And Salvatore, our good friend in Valencia, Spain, and all my friends around the world that have been working so hard to try to find ways of improving our resin bond strength. Because every time that you etch a tooth, every time you etch, even with a self-etchant on dentin, the tooth is responding. The tooth begins to react because of the acid attack, because there's no way for the tooth to know what's the difference between the acid that you're placing on the tooth and the acid attack from the caries. And remember, all of our composites are acidic in nature. So all of them are going to set off a chain reaction of response from the tooth when we bond it. So we have to try to increase our bond durability by essentially reducing the response of the matrix metalloproteinases and the cysteine cathepsins, et cetera, and so forth. So we need to protect things where we possibly can, because no matter if you self-etch or you total etch, Lorenzo Bresci and Annalisa Mazzoni have shown us in their work that it is going to respond. It is going to have this catalytic breakdown. The enzymes are just going to go up and start to destroy it. So what we need to do is start to look at other ways of managing things. At the college, we've been using a quaternary ammonium silane cavity cleanser, which basically disinfects and enhances bond strength because it's able to crystallize and enhance the overall ability of reduction of the proteolytic enzymes, and then we restore to that as well. So we continue to look at what is evidence-based in the literature, bringing it to our students. So this way we can enhance everything that they do. And again, there are so many different ways of increasing bond strength, but one of the most important things to do, again, is isolation, making sure that you use a good and a cavity cleanser. We can talk about glutaraldehydes and chlorhexidines, and I've got an entire lecture and a half on that, but we're not going to go there. But at the college, we don't use chlorhexidines or glutaraldehyde significantly anymore. We're using the quaternary ammonium silane material called Fightback, and it has been a remarkable enhancement to everything that we've been doing, developed by incredible scientists all around the world, validated over the last 10 years. So that's one of the things that we're doing. There's also some newer antimicrobials based on a quaternary ammonium as well. You might have seen the Nobio, Nobio antimicrobial composites and bonding systems. The entire arena is evolving into this to try to stop the bacterial incursion. But if you still have voids, if you didn't place your composite properly, if you didn't get a good gingival seal, all the antimicrobials in the world may not be effective in stopping the progression of a problem eventually over time. So again,
which is going to go back to what we're going to talk about, these techniques. And right now, John, I'm seeing that I'm sure there has to be questions. So please don't hesitate to put some questions in the chat so we can get a little bit of exchange, a little bit of Q&A going.
That's going to help us, yeah. Because we got over 400 of you on this, and we would love to get any interesting questions that you have. So
everybody is familiar with selective etching versus total etch versus self etch. And these are just, techniques that are used by the majority of dentists out there when placing composite resins. I always show this slide because I like the selective etch approach, particularly with the universal materials. Now, you can do either selective etch, self etch, or total etch. But you see this little finger of composite that's coming over the margin here. When you're placing your composite, I like to, before curing, take a sable brush and just brush from the composite toward the margin to get that little excess going over the cavo surface margin, so that when you do finish back a little bit, you avoid white line and you avoid issues with that. That's a Ron Jackson technique that's been around for a long time. So selective etching the enamel only. Of course, we know we get some dentin when we etch, and then rinsing 15 seconds later. But John and I have been around for all of these things, and we'll talk a little bit about placement now with the traditional composites with the triangular, the different walls and C factor and all this stuff versus, and we came out with some bulk fill materials to fill the majority of the cavity, or quote unquote become a dentin replacement, and then true bulk fill materials now that they call bulk fill packables or condensables, that literally create a singular monolithic block of composite, effectively eliminating layers. I think that's a goal that we should have as far as in placement, because anytime you're layering composite, my layering, your layering, who's ever layering, there's always the ability for micro leakage and damage. Yep. So, John, give a little bit of your background. I remember you told me you always place those diagonal little wedges of composite because you were told that you couldn't take composite across from cusp to cusp because you'd pull the cusp together and cause sensitivity.
And I wish that I had the patience and the ability to do the traditional layering. I don't know of anybody currently or even in the past that really was able to do that layering technique. It's absolutely mind. How much time would that take? You figure, condense it, put that into place, cure it for 10 to 20 to 30 seconds, put the next one on. You're almost 5 minutes into it before you even get to the occlusal surface, which is why one of the biggest challenges, of course, is making sure that we don't have polymerization shrinkage and polymerization shrinkage stress. So when you're using a traditional composite, you need to make sure that you're only building it up in 2 millimeter increments. The bulk fill materials, as illustrated here, enable you to build them up in the 4 millimeter or so increments in order to get things done faster. But you also have to make sure, again, it comes back to your light. If you don't have a good light with this, you're going to create that mush that's in there as well.
Well, and John, Chris brings up a good question there that plays right into where you were going with this, because he was asking about any disadvantages to using dual cure composites like bulk EZ, and I'd say actually no. I mean,
no,
with a dual cure material, you take away some of the problem with depth of cure. Is that not right?
A dual cure material, basically, because it's going to self-cure on its own, in addition to being activated by the light, is an absolutely perfect material. We use dual cure materials in the clinic, and our students love them, especially in the dark holes. So adapting a good dual cure material into the area, and if you can get it to actually flow into the region appropriately, then you've got an opportunity. And I think this comes into play. We can do a little bit about warmed composite here, Bob, for just a couple of seconds. I think that might be a very helpful aspect. So let me share my screen on this. And we can just talk about that quick. Yep. And then I'll share my screen here.
While you're doing that, we have another question. When you've isolated etch for whatever reason, the patient has to cough or can't tolerate the bite block. I think the basis of the question is, what happens when you're in the middle of procedure and you get contamination, salivary contamination on the prep? what do you do? Do you start over again? In other words, you have to re-etch, rebond, do all those things. What do you think about that, John?
Well, in my opinion, you're probably going to have to in order to make sure that it is going to be more effective. So let me see, do I have this on the right screen here? I think that one is going to be, well, it's being interesting. We'll go one more time. So on the first slide, you can see here the various types of warming composite tools that are available out there. And my friend Nate Lawson and his colleagues at the Dental Tubule Instagram account have a lot of really cool ideas. And again, Nate must have been knowing that you and I were going to talk about warm composites, because he looks at on the upper image here, the CalSet warmer, a coffee mug warmer, and the new Compex gun. Now at the clinic, we're using the CalSet warmers, the ones that has just enough for only just the compules itself. This way we can have our students be able to call for warm composite into the areas, and also the Compex HD gun, which is really pretty nifty as well. So let me see if I can bring up this video and show you this really quickly.
Hi, we're going to be demonstrating the differential between a regular non-heated composite and a heated composite. We're going to be demonstrating the Compex HD by Advent. Right now the material is heated because we have green lights on the back. You stop and start it from the back. And the compule is now inside of the special protector. And this is hot right now, right in through here. And that's really great. We use at the college the CalSet warmers, which heats up multiple compules of material all at the same time, so that this way when the student is ready to restore, they can certainly go ahead and call for a heated composite. We heat all of the various shades. We have several of them distributed throughout the clinic. But just to demonstrate how fun it is to bring out a regular composite and trying to get it into the preparation here, you'll notice I have to put a lot of pressure on that. And again, it's not too terribly bad to extrude the material, but you can also kind of see that it's very stiff. And it takes a lot to make sure that the material is adapted well to the insert of the preparation. So this is your typical class 1 restoration here. Now, in contrast, when we're using a heated composite, especially the one in the Compex gun here, we're going to see that I don't have to place a lot of pressure on the handle. It's just going to kind of zoom right on out. Look how fast that all came out of there. And then I can condense it into place, quickly adapt it, and go on, cure that, and then move on to the next layer. The key component when you're using a heated composite versus a non-heated composite is how much stress you have to place on that to get it to extrude out, as compared to the heated composite that'll just kind of float right on out. Initially, there's a lot of difference how easily it's able to adapt as compared to the regular composite. This is going to have less shrinkage stress and a higher conversion of the monomer and easier aspects to just adapt to your preparation, which is why our students love having the heated composite in the clinics. And again, many of them have used this device in clinic and love this as well because your material is always warm. One of the really cool features of this is from a disinfection standpoint. This overall plastic coating on the outside, this barrier, is really very easy to work with. But when you're ready to change your composite, you just pull off that rubberized sleeve, press down on the top, and that composite pops on out. Then you need to put new composite in. You pop that into place, reapply your rubberized sleeve, right on over it again, making sure that you get everything lined up, bringing the cannula out and making sure that you push it so this way the tip comes out of it. And in about 30 seconds, this is ready to go again. It's a very quick and easy device to work with. And again, the infection control barrier is extraordinarily nicely done.
Now, I think, John, the biggest point to be learned here, because we can't really see really close up on there is this. It's not so much how difficult it is to extrude the material out of the cannula. Think of that material when it's being extruded, and is it actually adapting to the internal geometry of the cavity? The answer is no. So you're more dependent upon this quote unquote condensing and pushing to get that material adapted to the cavity. Versus with warm composite, the lower viscosity of the material, you're really not condensing this material. You're placing it into the restoration, and because of the warm viscosity, it's adapting by itself. All you're doing is shaping the occlusal portion of that to render your anatomy. So totally two different mechanisms of placement here. And one, obviously, you can just by nature of the viscosity of this material, which one's going to be better adapted? The warm material that flows into the cavity, or the stiffer material that you have to push and push and push and hope by blind faith that it fills those areas?
And that's one of the reasons why, again, using a dual cured material, and if you have a dual cured material that you can warm up, you're going to get even better adaptation to the entire cavity preparation in and of itself. So a dual cured material, we use Activa bioactive restorative material in the clinic all of the time. That being a dual cured material, especially in the deep dark boxes, has been a very giant asset. And you can use that to just take care of the internal aspect of the box and then place another composite on top of it if you so wish, or you can fill the entire preparation with that material. And our students, again, have been exposed to these different types of materials, and they're absolutely enjoying, because when they get into private practice and they come upon these materials, they know how to use them right out of the gate. So that's really very important.
And
So
the advantages
material
and
is great.
disadvantages.
Yeah,
I know
exactly.
with Kashama's question up there, we kind of glossed over it, but if you get contamination, do you start again? I mean, obviously, if you're going to get contamination, it's best to decontaminate and start again, obviously.
Yeah.
So etch and rinse and reapply and do that. BJ asks about, and then John, this goes right to you, because Dr. Kamisi has been a glass ionomer guy for a long time, and I'm very familiar with the material and use it quite a bit too. But speak to the many benefits of glass ionomer as a base. Now, I wouldn't necessarily, BJ, refer to that as a base. I'd refer to it as a Denton replacement before placing composite. So John could tell you a lot about that, BJ.
The overall coefficient of thermal expansion of a glass ionomer is similar to that of Denton. So having it as a Denton replacement is actually quite desirable in that aspect. So we certainly we do teach that. We do teach the open and closed sandwich technique in the clinic and in my class that I teach the second-year students. It certainly has its benefits. The biggest challenge, of course, is sometimes the adaptation and the application of a bonding agent to the glass ionomer itself. Now, there's a couple of studies that seem to indicate that you can bond to a glass ionomer with a bonding agent. I have had a difficult time with that over the course of time. If your material has a high 10 MDP in a very purified way, maybe you'll get some nano layering with the calcium in the calcium fluoroaluminosilicate glass. But again, I personally would nowadays, because of potential for washout, especially in the open sandwich deep in the box, I would probably use a resin modified glass ionomer in that capacity, because you get the benefit of a dual cure in that, and you get the resin fortification. And that's also where something like Activa comes into play, because it is a ion releasing material, and putting it into the deeper box in the same way that you could use a glass ionomer would be beneficial as well. But a GI or a resin modified glass ionomer certainly has all kinds of good benefits. So I would never shy away from doing that if I have that need. So having that in your armamentarium, in your bag of tricks, is always a great thing to have, for sure.
Well, I think one of the challenges with glass ionomer and Denton replacement has always been, mixing the capsules, and glass ionomer has a very short working time where you can actually adapt and pack. It's either too creamy and too mushy, or boom, it sets up like a rock. John and I have worked with many of the glass ionomer companies over the years, and finally GC came out with a paste delivery for their Fuji Auto Mix, and it's you can deliver it literally right to the tooth. So that does save on the delivery aspect. Like with warm composite, it saves on the time between getting the material into the tooth and placing it to get ideal adaptation.
Lena asks, what's the easiest to use glass ionomer? Good question.
Well, just talking about that, I mean, I think that, you know, the new GC version of Fuji 2 Auto Mix is take a look at that one.
Yeah, and that's a resin modified glass ionomer. So, in the way that they've developed it, it could be beneficial in that aspect. While we're on this area, we've got one more from Sharon. She's seen some doctors use Bond to manipulate packable composite, or pros and cons of that. You know, again, you need some kind of wetting agent to enable you to manipulate the material. Again, as we talked earlier, there's no such thing as a packable composite. Why don't we go to the DME section of the presentation, Bob? So this way,
Okay.
we're at about 740 right now.
Yeah.
So that's slide 50 something or other.
Got it.
So talk about that, because that fits right into what we're talking about right now. The biggest, you know, the problem is, or the thing is, that you want to make sure that you're using something that isn't going to evaporate and cause some challenge to the composite itself. Many years ago, Mark Patel wrote a paper on manipulation of the materials with various things like alcohol, bonding agents, et cetera, and so forth. And one of the things that he talked about in there was using an unfilled resin to manipulate it, because it doesn't have any volatile acetones or alcohols in there as the bonding agent will. You're going to get a much more beneficial result. So there are a lot of different unfilled resins. Bob, you were showing me one from the Clinician's Choice the other day. That was very interesting. So there's quite a few of them that would be available that I would suggest you look at. But using a wetting agent to manipulate things is very important, because, you know, you want to be able to shape and manipulate your composite to where you want to, which again comes back to a heated composite. If you have a heated composite, maybe you don't have to manipulate it in quite the same way or make it as difficult. But again, an unfilled resin material to manipulate and wet the composite is certainly not a bad idea.
And John, Veronica asked a question here that you can roll into deep margin elevation. She's talking about the role of plaque being overlooked as prophene prior to restoration. Is that a major?
Yeah.
Absolutely is a major factor.
Yeah.
As I always say, if patients don't know which end of the toothbrush has the bristles, I mean, this is an important decision for the doctor as to the type of material that you're placing. And John and I are big advocates of bioactive filling materials and materials that release ions to help lower the ability of plaque to stick to teeth and biofilm.
I think also she's mentioning the need to clean the teeth prior to restoring it.
Oh, well, absolutely. And I mean, that goes without saying.
But you wouldn't use a prophy paste, because that has a capability of having fluoride in it, which would interfere with things. You want to make sure you're using a flour of pumice to clean the tooth, or one you can use air abrasion, and that will also help to clean the tooth off. Something you want to make sure that you're using something that is not going to bind to the tooth surface, but it's going to clean off of all of the plaque that's on there. You know, there are various types.
What does Dave Clark use in his?
He uses a tricalcium silicate or something, or I can't remember the exact thing. But again, he blasts all of his preparations before he restores them. Before he even starts preparation, he is cleaning everything. So if you got to clean the junk off of the teeth to see, first of all, where you're prepping to, and then you move forward. And then again, once you're done, you want to debride and clean up the preparation to make sure there's not any smear layer there. So that's another key component. So definitely,
good question,
these
Veronica.
are great questions. Great questions, everybody, so far. We love it. So let's talk about this deep margin elevation, because this is another arena in which we really have seen a very great interest going on. We're teaching it at the college. We're trying to explain that sometimes you can restore a tooth that has a deep area of decay as long as you can maintain the biologic width. This is really the very important component of this. You need to make sure that your biologic width is maintained all of the time. Otherwise, it's going to be an issue. So this could be a substitute if the biologic width is not impinged upon to any other situation. Pascal Magnier has talked about this for a long time, and again, it's a really interesting technique. Pascal likes to use a flowable composite, and one of the biggest challenges, and again, I hate not agreeing with someone as remarkable as Pascal. But again, I get concerned when we use a flowable composite. What type of flowable composite are you using? If you're using a low filler type of a flowable, you're going to have an issue because you're going to have a great deal of shrinkage stress because it's a low filled material. If you're using a higher filled flowable material, what is to stop it from not flowing properly? If the viscosity is such, then you have an issue. So that's where a warm composite in there, whether it's a flowable composite or a warm regular composite, can potentially substitute for that kind of a flowable composite, have less shrinkage stress, have a higher conversion going on, less shrinkage overall, and probably adapt as well as a regular composite. And we have to worry about costs in our office, and sometimes we have so many different products that we don't always use them all. So if you have a heated composite, and do you really need a flowable composite? So that's something that we can discuss among ourselves as time goes by.
But it's something we can discuss more in our next webinar next month, because I think there is a lot of confusion on the materials aspect, and I think we can spend a little bit of time and focus on that in part 2, John.
There's a great question here that Sagafi just asked about heating and cooling of warmed composites. Have there been any negative effect? And actually, there is no negative effect. We do it all the time. We start the heaters up early in the morning, and they're used throughout the day. And if the composite that's in there wasn't used, and it's cooled overnight, we've refilled those composite wells that were used, and we just place the new ones and heat them up again and again. So there's no studies that have ever shown. There are studies never shown that there's any detrimental effect of warming and cooling of composites in these heaters. So I have no problems and no qualms on that.
In fact, how much warming and cooling happens to these materials in the oral cavity?
Right.
Drinking hot coffee and then iced tea. I mean, we're always talking heating and cooling.
Yeah, and in the uncured situation, I don't really think we have an issue with that. So we're in good shape there. Let's go back to the deep margin elevation while we have the opportunity. Again, we have a lot of really good things going on here because, as I said earlier, if we can raise up, and Bob, if you go over to the lower blue line area there, see where the bone and the composite and the restoration are. You have to have that minimum biologic width, 2 millimeters or so, before you can do DME very effectively. So you need to be very careful of that. You need to radiographically analyze it. Is it going to work? If you have biologic width, deep margin elevation is a beauty. You definitely want to consider that.
Or so sound in this, with a perio probe.
Yeah, you want to make sure that you have enough space. And again, in this situation, it's using a flowable composite. You can do that. Why not consider a warm composite in that area, or use something that's got some bioactive capability of releasing ions like Activa, or something like that material. It can really help to give you more bang for your buck, and then put on your adhesive and restore and do everything else that you need to do. So again, that's some of the things that you may want to consider as you go forward. What's our next slide, Bob? Yeah, here you go. So this is a really nice slide that I stole from Marco Venezzi. This is his article, Uniform Journal of Aesthetic Dentistry 2010, and this is beautiful. This shows you where you're going to be and where you don't want to use DME. In grade 1, when you've got great rubber dam isolation, great biologic width, then you can do the work that you need to do. In grade 2, you've got rubber dam isolation is questionable, you have good biologic width, you can put in the material, half a millimeter build up as you're going forward. But if you have poor biologic width and you can isolate, your only rationale then is to either do surgical crown lengthening or root extrusion, which is another alternative that we use at the college to bring the tooth out of the socket. And it's a good additional consideration to the overall crown lengthening, because when you crown lengthen, you're not only affecting the tooth that you're crown lengthening, you're affecting the adjacent teeth as well, because you're removing bone to enable a more healthy overall natural contour of the tissue and the bone that goes on in there. And then we have this diagram here, which does the illustration of deep margin elevation, and it goes through the various steps. Now, one of the key components here is you're looking at steps 6 and 7. They're in particular very interesting, how you're placing the matrix so that this way you have proper adaptation. If you're not wedging properly in that area, it's going to be a mess. So your matrix is really very important in that area. So this illustration is really great, and it's from that article that I just showed you as well a few moments ago. Question here by Hisheba Shapika, I'm sorry if I killed your name, using a little flowable composite and packable composite together. And again, Bob and I both agree that there's no such thing as a packable composite. It's a squishable composite, or it's a more highly filled composite rather than packable. So we'll just, and you can, again, I have qualms regarding that, putting down your flowable composite and then putting composite on top of it to try to get everything to coalesce together. I don't know if that works well. Personally, it's never worked well for me. Bob, have you done that in any of your restorative work?
For years, I would put a layer of flowable down and cure it, and some people were, and then restore with the paste composite, the traditional composite. And some people would put down flowable and not cure it, claiming it would squish out all over the place. I've heard, was it the snowplow technique or whatever that is?
Yeah.
I'm not so sure I'm a big fan of that. I mean, unless you got a perfectly hermetically sealed matrix. But the question here, I think, goes to if you're using a heated composite, you really have the benefit of both. Next month, I'll talk a little bit about my experience with Sonic Fill, if those of you have used Sonic Fill before.
Yep.
And Sonic Fill really filled a void as far as having the advantages of a flowable and a quote-unquote packable, if you want to call it that. But the problem with the Sonic Fill is you needed an extra handpiece, and it was a proprietary composite. You couldn't use only their composite.
It's a bit costly.
Right. So I think you get a lot of the same benefit with composite warmer because you can use any type of composite. And you as John mentioned, I would say you probably eliminate the need for flowable, except in those little micro slot preps, John, that you have the sophomores prep in technique lab.
Yep.
Sometimes it's a little hard to get a regular cannula down into those things.
Yeah, that's true.
And so when you're talking about microdentistry, and things like that, micro-invasive, we like to use flowables in those situations, and particularly Activa Presto, because it's
they're small, and you can get the cannula in, cures nicely.
They're small, and plus they have release of calcium phosphate. But Zach is talking about Magné's article where he suggests that marginal elevation doesn't necessarily need to abide to biologic width parameters. I think my thought on that is over the years, I've done a lot of crown lengthening. I haven't done a lot of deep margin elevation, but I will tell you this as far as biologic width goes. I've seen patients where biologic width has been invaded and the gum is pink and it doesn't bleed. I've seen patients where you invaded by 1/10 of a millimeter and the gum is soggy and boggy and bleeds like crazy. The question is, and what I would ask Dr. Magné is, how do you know the difference clinically? The answer is you don't.
Yeah.
So
you don't know how it's going to respond, and that's the biggest challenge that you've got there.
That's the biggest challenge. So you
Yep,
want to be on the
agreed.
safe side of predictability, play by the rules, Perio by the numbers, and there's going to be situations where, you know what, for the best long-term result, do a crown lengthening.
Yep. Yep, I agree. And this last question by Bernard is an interesting one. Reverse margin technique. I'm not familiar with that. Bob, are you?
I'm not familiar with that either, unless he's referring to a reverse bevel. But that goes back to, gold onlay and
Yeah,
things
Bernard,
like
can
that.
you type in
Maybe Dr.
what it is?
Bernard can.
Well, we've got a couple of
rephrase,
seconds.
Emil Svoboda.
Not many.
I'm not familiar with him.
Why don't you reach out to us, Bernard? We'd love to know a little bit more about that. Communicate. My email, I think we've got that at the end of the program. You reach out to us. I'll give you mine, and Bob will give you his, so that this way you can reach out, because that's an interesting question. My email is really easy. Revolutionary. Yeah, I would say. Let me just put my email into here, so this way you can reach out to me, because I'd be very interested in learning more about that.
Well, you see, that's the nice thing about doing these things is a lot of times, John and I, we learn just as much from the people taking the course as we do giving the course. So it's always very interesting and challenging to learn of new techniques, because as I've always told my students, anybody that thinks there's only one way to do things in our profession, they're not living in the same world that I live in.
So our next lecture, again, my email for everybody that didn't see that is Comisi, my last name, COMISI @MUSC.edu. Please reach out. I'll be happy to try to figure out answers that we didn't get to this evening. Our next lecture is, when is that, Bob? Is it June or July?
It's in June.
Is it June? Is it a Monday?
I'm going to stop sharing for a second. I'll pull up my calendar.
Because I'm trying to find it, and I can't remember when it is. But we'll be on the lookout for it, because we're definitely going to have a lot of fun doing that.
It's on Tuesday, June 14.
That's why I couldn't find it. Yep, June 14th at 7 o'clock Eastern. We'll be doing this again. We'll be adding into more areas. So again, for those that wants that, I'll give you my email one more time.
And I'm looking on my phone about Svoboda reverse margin, and it looks to me like they're showing some system that has something. What they're showing the picture is actually a implant code.
There's our email. There's our emails right there. So you can reach.
But he's talking about
Bob and I at
several
either
root causes of mechanical complications related to prosthesis installation. So
interesting. That could be fun.
It looks to me like it has something to do with implants, but we'll do a little bit of research on that.
We'll try to look at that for next time.
When talking about margins is biologic root reshaping, and all that has to go along with that. But that's getting into another interesting area that we'll have to develop another program about, because in those areas we would be getting more into the indirect realm. And
one question down here: can we do a lecture regarding video changing without ortho treatment? That could be fun.
Oh yeah, I've got a few cases we could talk about. Talk about that. Absolutely. Thank you everybody for your kind attention tonight, and we hope you like this different approach to presentation, because so many times we just get one of us, John or I, will be out here and just show you our slides and talk to our screen, and I like this interactive thing where we can answer questions and talk about different things, and let the folks at Viva know how you like this format, because John and I would like to do these on a regular basis, and I think it's a nice way to reach out.
And a quick shout out to Bob, and a quick shout out to Trevor Wolf, who's stated something about glass ionomer. And again, I don't discount glass ionomer. I'm one of its biggest fans, and I agree with you.
And I myself as well.
So we never discount it, because we know it's a very valuable tool. So certainly, Trevor, I want to assure you that we teach our students glass ionomer, and we want to make sure that you understand that we have a respect for it as well.
And the short answer to that too is, glass ionomer is a great material, but in the posterior occlused load-bearing areas, you need something on top of it because it's just doesn't wear.
Yeah. But we can discuss that further at a different time.
We
even
will
more.
go into that next time.
Yeah. All right. I think we're at the end of our time period. I think we've got less than a minute, and they're going to want to give the information as to how to get your CE credits for this
So we
evening's
will,
lecture.
I think, Trung, we have to give up the sharing of the screen, or?
Nope, you guys are good. Thank you so much.
All right.
Okay.
All right.
We'll see you next month.
Definitely. Bye, everybody.